Hi, everybody. Thank you so much for joining us today. So sorry about the delay. There's just a few little technical issues, but we're going to get right into it now. So thank you everyone for joining us and for our webinar on updates in primary CNS lymphoma. I'm Nicole and I'm one of the lymphoma care nurses with Lymphoma Australia, and I'll be your host for today's session. And I'd like to thank Associate Professor Matthew Ku, who kindly will be presenting for us today. So, housekeeping and technical issues before we dive in, just have a few quick things to mention. So, we encourage your participation in today's session. So, if you have any questions, please put them in the Q&A function at the bottom of the screen, as the chat function will not be monitored, and we will have the questions and answers at the end of the presentations. If you miss anything or would like to rewatch the session, it's actually being recorded and we will upload it to our website. And this link will be sent to your email once the recording is available. And if you have any technical issues during the webinar, please email nurse@lymphoma.org.au and we will try and address this for you. So we have Associate Professor Matthew Ku, and he is a clinical and laboratory haematologist and lymphoma clinician and researcher. His academic career is significant due to his involvement in both lymphoma clinical research and teaching while working in a full-time clinical capacity. His leadership roles include co-deputy director at St Vincent's Hospital, Melbourne, clinical haematology, aggressive lymphoma tumour stream lead. St Vincent's Hospital, Melbourne, Immune Effector Cell Steering Committee chair, and St Vincent's Hospital, Melbourne, Grand Round Committee chair. He is a principal investigator of 32 clinical trials in lymphoma, with collaborations with the ALLG, ALA, and St Vincent's Institute. He is on global scientific advisory boards, and he established the first clinical trials collaborations in lymphoma between the ALLG and the Nordic Lymphoma Group, as well as the ALLG and the Italian FIL Group. He is currently the coordinating principal investigator of two multi-centre international investigator-initiated trials in lymphoma with associated translational and correlative studies. To date, he's published more than 50 peer-reviewed papers and over 70 abstracts at the international scientific conferences. He had been invited speaker at the lymphoma at multiple meetings and conferences. Associate Professor Ku's ultimate goal is to establish strong national and international collaborations in lymphoma research that will result in improved evidence-based patient management, leading to better outcomes and prognosis. So we'll now get started and I'll hand it over to Matthew.
So good afternoon, everyone. Thank you for your kind introduction. And thank you for the opportunity to present on this very important blood disease, primary CNS lymphoma. So today I'll be introducing what primary CNS lymphoma is, talk a little bit about the presenting features, the diagnosis, and then launch into the management and the treatment options for this disease, as well as the prognosis. Some of the abbreviations I'll be using today, including CNSL, meaning central nervous system lymphoma, NHL, non-Hodgkin lymphoma, HDMTX, high-dose methotrexate, SCT, autologous stem cell transplant, WBRT, whole brain radiotherapy, and CSF, which stands for cerebral spinal fluid. And I'll get into what these terms mean later on in my presentation. Now, what is lymphoma? Lymphoma is basically a collection of blood cancers of the lymphatic system. Now, the lymphatic system is a system that disseminates throughout the body, and it contains lymph, which is a colorless fluid that carries a type of blood cell called lymphocytes. Now, these lymphocytes normally make antibodies in us, and these antibodies destroy harmful microorganisms, such as bacteria or viruses. However, when these lymphocytes undergo a malignant or cancerous change, they can become lymphoma. And typically, patients with lymphoma present with either swelling or enlargement of their lymph nodes, or what we call B symptoms, which include fevers, night sweats, particularly drenching night sweats, and body weight loss. So 10% or more body weight loss. Now, as you can see here, the lymphatic system in the diagram is, as I said, disseminated throughout the body and includes not just lymph nodes or the lymphatic system, but includes other organs such as the tonsils, the thymus, the spleen, and as well as the bone marrow. As you can see, within the bone marrow here, you've got different types of blood cells, the red cells, the white cells, and the platelets, and the lymphocytes are part of the white cells in the bone marrow. Now, primary CNS lymphoma is basically a lymphoma that occurs within the central nervous system. The central nervous system comprises of the brain and the spinal cord and the surrounding space. It is a rare, aggressive, non-Hodgkin lymphoma. And as I said, it can involve the brain, the spinal cord, the fluid around the brain and the spinal cord called the cerebrospinal fluid or CSF, and the eyes as well. It is not a common cancer, comprises of only 4% of all the intracranial cancers, so occurring within the skull, 4%, and 1% of all non-Hodgkin lymphoma. And unfortunately, the incidence of CNS lymphoma does increase as one ages, particularly above the age of 60. In the diagram here, you can see that lymphoma in general can be divided into Hodgkin lymphoma or non-Hodgkin lymphoma. So 70% of the lymphomas are non-Hodgkin lymphoma. Within that, the central nervous system lymphoma accounts for a small proportion or small fraction of it. So lymphoma within the central nervous system can be primary or secondary. Primary meaning that when the patient was first diagnosed, the lymphoma was confined to the central nervous system, i.e. the brain or the spinal cord and the surrounding fluid. And 90% of the histology or the type of lymphoma is an aggressive type of lymphoma called diffuse large B-cell lymphoma. Secondary CNS lymphoma is when the lymphoma either involves other parts of the body apart from the brain or the spinal cord, eye diagnosis, or when the lymphoma relapses or recurs, it involves one of the central nervous system sites. As you can see here in the diagram, as I mentioned, the CNS involves or comprises the brain and different parts of the brain, the cerebellum, and the spinal cord. And the spinal cord obviously travels down from the brain down to the chest and the abdomen, and it comprises of all the nervous tissue from the brain downwards. And within the spinal cord, the space is covered by 3 different layers. One's called the pia mater, the second is arachnoid matter, and the third is dura mater. So any of these spaces that are involved by lymphoma would be classified as central nervous system lymphoma. So typically what happens when a patient presents with CNS lymphoma, there would be either a lesion or a tumor detected on a scan such as this. So you can see these are MRI scans of the brain. You can see that the brain's meant to be symmetrical on the MRI, and you're meant to have 2 spaces called ventricles that are black on the scan. However, in these pictures, you can see a big lesion or tumor that is compressing on the brain and the ventricles, and therefore you can see it's pretty asymmetrical, okay, on all these scans. And obviously, it's hard to tell on the MRI here, but usually you can see some swelling associated with the tumor itself as well. Now, who can develop this type of lymphoma? Well, anybody can really get this cancer, but it's more likely if you're older, as I said, more than 60 or 65. And if you're male, unfortunately, as with all cancers, males tend to have a higher incidence of cancers. If you're immunocompromised from conditions such as HIV or other similar conditions, or if you're immunocompromised because of the medications that you take. So as we know, a lot of autoimmune conditions, so conditions that involve the immune system being too hyperactive, a lot of these patients are on immunosuppressants, and sometimes these medications can unfortunately lead to a higher risk of CNS lymphoma. Now, CNS lymphoma is a complicated disease and it requires multidisciplinary team support. So not just a hematologist or an oncologist, but also often involving neurologists, ophthalmologists who are the eye specialists, radiologists, neurosurgeons, and radiotherapists. And that's because the lymphoma, where the location is within the brain or the spinal cord, can be quite tricky to treat and diagnose. And the management can vary depending on both the patient as well as the disease factors. The way a patient would present with CNS lymphoma depends on the location of the cancer or the tumor, usually. In up to 70% of cases, the CNS lymphoma can present as a solitary lesion, meaning a tumor that you can see on the scan, either in the brain or in the spinal cord, less commonly in the spinal cord, more common in the brain. However, the tumor cells can actually infiltrate and disseminate through the space and the fluid around the brain and the spinal cord. So the fluid around the brain and the spinal cord is called CSF, okay? And the meninges are basically the covering of the brain and the spinal cord. And often when there's dissemination to these other areas, patients can initially be quite asymptomatic and well. Now, the aim of staging, so at the beginning, before we start treatment, once the diagnosis is made, we want to make sure that the disease is staged. And staging means that we want to know how extensive is this disease within the different parts of the central nervous system, but also to rule out lymphoma involvement elsewhere outside of the CNS structures. So as I mentioned to you before, a patient with CNS lymphoma can present differently depending on the location of these tumors or lesions. So patients can present with what we call focal neurological deficit. So whether it's arm weakness or leg weakness or weakness down half the body, almost like a stroke, that can occur with a patient with CNS lymphoma. And also patients can present with neuropsychiatric symptoms. So almost like someone having psychosis or even dementia that can occur with someone with CNS lymphoma. Loss of higher cognitive functions. So as I mentioned, almost like a dementia, so memory impairments or visual disturbances or pain, especially back pain if there's spinal cord involvement. So spinal cord involvement, as I said, it's uncommon. And unfortunately, because it's uncommon, especially for the non-hematologists, the diagnosis can be delayed, unfortunately, initially. And so, you know, we as physicians need to be very vigilant in terms of diagnosing uncommon cancers like this. Now, if the lymphoma is only isolated to the eye tissue, there's a particular subgroup of lymphoma called primary intraocular lymphoma. That's basically when the lymphoma is only involving the eye tissue. And that's treated somewhat differently to your standard CNS lymphoma. So patients, again, can present with nausea and vomiting, weakness of the arms, legs, or face, hearing loss, difficulty swallowing, signs of brain pressure, so increased brain pressure, so headaches and confusion can occur, visual problems we've already talked about, changing the mental states, seizures when it's really severe, and if the tumor resides in the part of the brain that can cause seizures, and that can occur, and again, patients will often present and then have a scan, and a tumor then will be detected in that area. When the spinal cord is involved, patients can have urinary and fecal incontinence due to spinal cord compression. So as I mentioned to you before, CNS lymphoma can be tricky to diagnose and manage, and usually requires multiple different types of investigation. So obviously as a hematologist, the first thing we would do is to take a proper history and extensive examination, including eye examination, to see whether we could find lymphoma cells in the eyes. But then we would go on then to do other tests if the suspicion for CNS lymphoma is high, such as blood tests, scans such as MRI, CT scan, and PET scan. We often will have to, especially if there's a discrete or isolated tumor lesion within the brain or in the spinal cord, to require a tumor biopsy. So a little chunk of that tumor needs to be taken out either through surgical or through a needle biopsy to make sure it is lymphoma, because obviously other types of cancers can also occur in those areas. Lumbar puncture, which is a method of extracting some of the fluid around the spinal cord and the brain out through a needle in the back, and looking to see whether there are lymphoma cells in there. Sometimes patients may need a bone marrow biopsy just to make sure there's no lymphoma within the bone marrow as well. Now, because testicular lymphoma can also impact on the occurrence of CNS lymphoma, and therefore patients will require, obviously male patients will require to have a testicular ultrasound to make sure there's no involvement of the testes by the lymphoma. Now, just a diagram here demonstrating that the blue area, that's the fluid around the spinal cord and the brain, called this CSF. Now, that's the fluid where the lymphoma cells can disseminate, and therefore doing a lumbar puncture can then allow us to extract fluid and analyze the fluid using highly sensitive methods. Now, in terms of management, so the first thing I'll talk about is frontline management, meaning that this is the first round of treatment or first line of treatment for a patient that's been diagnosed with CNS lymphoma. So because of the fact that the majority of the patients, unfortunately, don't get a cure out of the chemotherapy, therefore, it's also always important to consider enrollment onto a clinical trial using new drugs wherever possible when a patient presents with CNS lymphoma. Now, most of the lymphoma patients, when they present, they would receive immediate steroid, whether in the form of dexamethasone or prednisolone, just to relieve the CNS of the lymphoma. And usually it's associated with a very fast symptomatic relief, up to 40%, actually start to get improvement even just with steroid initially. However, steroid is really just the initial phase of treatment, and more definitive treatment, such as chemotherapy, is required to further reduce the lymphoma within the CNS. And if we have a young patient who is able to tolerate intensive treatment, the intensive treatment for CNS lymphoma would involve two phases. The first phase is induction, usually induction chemotherapy, and then consolidation. And consolidation can be done either using radiotherapy or stem cell transplantation. And consolidation means that once the patient has achieved a good response with induction treatment, we just want to give the patient additional treatment to consolidate that good response and trying to keep the lymphoma at bay. And that's, as I say, usually in the form of stem cell transplantation or radiotherapy. Obviously, the treatment should be individualized, because no patient's the same as the next patient, and no disease is exactly the same as the next disease. So we need to make sure that whatever treatment we're offering can deliver the best outcome for the patient. So maximizing the effectiveness of the treatment and minimizing the side effect profile. So as I said, for patients, especially that are young and robust, can tolerate chemotherapy, the frontline option would involve chemotherapy. Now, there's one particular drug called methotrexate, which at very high doses is really the mainstay of therapy for CNS lymphoma. And so whether it's high-dose methotrexate by itself or in combination with other drugs in regimens such as what we call matrix or IMPV regimens, that's the preferred first-line treatment for someone with CNS lymphoma. Now, obviously, for the older and less robust patients, adjustments in terms of doses and how many drugs you would use need to be modified. And because of the fact that usually chemotherapy is pretty intense, and therefore there's a higher infection risk in patients that have received chemotherapy in this setting, and therefore effective prevention and management is very important. So we would often have patients on antiviral and antibacterial prophylaxis or prevention of these infections. So antibiotics, for example, but also, careful management and to prevent infections. So staying away from people who are sick, avoid sushi and blue cheeses and things like that can possibly carry infection. And then to present to hospital if a patient undergoing treatment develops a fever of 38 or above. So these are the sort of the advice we'll give to our patients undergoing chemotherapy. Now, apart from chemotherapy, the other major mode of therapy is radiation therapy, and you can either receive whole brain radiotherapy or localized radiotherapy as a patient with CNS lymphoma. And it is also an option as consolidation for patients who are older and unfit to actually receive a transplant. The third option, which I'll touch on towards the end of my talk, is more targeted novel therapies such as ibrutinib or CAR T-cell therapy. As I said, I'll go through those two therapies a bit later on in my talk. Now, I've already mentioned about stem cell transplant as a way of consolidating a good response after induction. So the transplant that we would do in someone with CNS lymphoma is usually autologous stem cell transplant, meaning it's the patient's own stem cells. So we would recover or harvest the patient's own stem cells and put them away and then give patients more chemotherapy to try and wipe out the rest of the lymphoma cells, and then give the stem cells back into the patient to repopulate these stem cells back into the patient after heavy-duty chemotherapy. It is also a method of treating somebody who's had relapsed CNS lymphoma. And finally, I've also mentioned about clinical trial, which is very important because the overall outcome for patients with CNS lymphoma is still unfortunately suboptimal, still not as good as people that have standard systemic lymphoma, and therefore clinical trials looking for better therapies is always a very important option. So as I mentioned, for patients that are young and robust, after the induction chemotherapy, if they're shown to have had a responsive disease, so if the treatments put their lymphoma into remission, they can then be consolidated with a transplant if they're young enough. For patients that have eye involvement, so vitreoretinal compartment, that's when you have lymphoma within the eye compartment, then in addition to the chemotherapy, quite often these patients can also get methotrexate through the eye injection. So that's usually done by the eye doctors, and we often refer ours to the eye and ear hospital doctors to get the intraocular or within the eye treatment with methotrexate. Now, for patients, as I mentioned, that are not robust or young enough to have the transplant, they will then be considered for radiotherapy. Now, we don't tend to do, especially whole brain radiotherapy, in patients that are older, above the age of 60. And the reason for that is we know that there's an increased risk of cognitive impairment with whole brain radiotherapy. So we've got to be very careful in using whole brain radiotherapy in older patients. So usually it's more recommended for younger patients that can't have a transplant as consolidation. So I've already mentioned about these recommendations. So consolidation after induction treatment is recommended and depends on the patient's age and frailty. It's usually either stem cell transplant or radiotherapy. And they, usually, both methods are pretty valid, but really the downside for the whole brain radiotherapy is the long-term neurotoxicity or cognitive impairment. So again, as I mentioned, it's not something that I would recommend for older patients above the age of 60. Now, this is a table, again, just demonstrating what I've already talked about. you've got someone with newly diagnosed lymphoma, you look at the performance status, how robust the patient is, and you roll into a clinical trial if possible. But for those that are fit to have intensive chemo, we talked about the intensive chemo containing high-dose methotrexate, and then consolidates in those that have good response with stem cell transplantation or with whole brain radiotherapy. For those that are older or unfit for intensive chemotherapy, but they still have a pretty good performance status and good organ function, like kidney function, quite often you can still use chemotherapy, either at a reduced dose or single drug, such as just the methotrexate without the other combination drugs. For those that are too frail to have any therapy, and it's more appropriate for them to be supported with palliative care measures, so symptomatic relief without any active treatment, you could think about a bit of steroid like prednisolone or dexamethasone, or some radiotherapy. And also there are novel drugs such as ibrutinib or CAR-T that can be considered. Now, as I already mentioned, chemotherapy and radiotherapy, they're the cornerstone for the treatment in this disease. Most of the patients initially respond to the treatment, but unfortunately in this particular disease, relapses are quite common. And not only that, usually relapses occurring, especially in patients who are not suitable for treatment with chemotherapy. So they start off with more gentle treatment, and quite often these patients, their disease just take off because they haven't been treated with more heavy-duty chemotherapy. And unfortunately, up to half of the patients can relapse after the initial treatment, and 10 to 15% of the patients are treatment resistant. So despite initial treatments, their lymphoma did not respond at all. So it is a disease that unfortunately does carry with it a poorer outcome compared to other types of lymphoma. Now, what happens with a patient that does have relapsed CNS lymphoma? Well, in this setting, the best treatment option is not established globally. So there are many different options available, but there hasn't been one that's been shown to be the best out of all the treatment options. So again, clinical trials should be the preferred option here to explore novel therapies or new drugs. Now, if a patient has had high-dose methotrexate a long time ago, let's say 7 or 8 years ago, and did really well and was in remission for all that time, and then the lymphoma relapsed after that, it is worthwhile considering challenging again with the original drug, in this case, high-dose methotrexate, to see whether you can get a second response again after the many years of remission. And obviously, if you've got a patient that has presented with a relapsed CNS lymphoma, as a haematologist, we will be investigating or restaging the disease to make sure there's no lymphoma elsewhere, as I talked about, staging the disease. Clinical trial should be considered, which I've already mentioned about. The treatment at relapse, again, much like treatment at diagnosis, it's guided by the performance status of the patient and the treatment goals and the prior therapy. So as I said, if you've got a patient that's robust enough to have more chemotherapy and the previous high-dose methotrexate has worked, and that was many years ago, and the patient's been in remission for many years, it's worth considering using the same therapy. Otherwise, it's worth thinking about alternative treatment options for patients that have had a quick relapse after the initial treatment. Now, patients that didn't get a transplant initially, but are still robust and young enough for a transplant, when they do relapse, it is worthwhile not just giving them more chemotherapy, but to consolidate it with a transplant. Okay. Now, point number 5, I already mentioned about repeat dose of the methotrexate. And also point 6, if they didn't really respond all that well with the initial chemo, then I think alternative chemo should be considered. And again, if the patient hasn't had radiotherapy with their frontline therapy, if they had a relapse, then I think salvage radiotherapy should be considered. And it's particularly palliative radiotherapy for a patient who basically cannot have any further therapy and are too frail to have any other clinical trials considered. Palliative radiotherapy is something that can be given just to relieve the symptoms, but also to reduce the tumour bulk and to delay the progression of the disease. Now, moving on to what novel therapies there are in the horizon. So some of these drugs have been used either in the setting of lymphoma or in other blood cancers for quite some time, but they've more recently been studied in CNS lymphoma. So one of them is called ibrutinib, which has been used and approved for other types of blood cancers like chronic lymphocytic leukemia or mantle cell lymphoma. But it has been shown to have efficacy in CNS lymphoma, so has been shown to be effective in CNS lymphoma as well. Another drug is called lenalidomide that's been shown to be effective in another blood cancer called myeloma, but also lymphoma as well. And the third thing is CAR T-cell therapy, which has really changed the way we treat lots of different types of lymphomas. It's really transformed the landscape for lymphoma treatment. So this is sorry about the diagram, looks a bit complicated, but I just want to show that this is within a lymphoma cell, and there are many different molecules and pathways that the lymphoma cell uses to either survive or to proliferate. And one of the targets is this molecule enzyme called BTK. And basically, the ibrutinib, it just inhibits this particular molecule and therefore breaks up this survival pathway that the lymphoma cell uses to survive and grow. And therefore, this is the way the ibrutinib, it's a mechanism of action. It's a way that it kills off lymphoma cells. And it's been shown to be effective in different types of blood cancers already. But it's also shown to be quite effective in CNS lymphoma. Currently, it's not approved on the PBS for this indication, but we are able as haematologists to get some free drug delivery from the drug company as compassionate supply. And quite often patients will still, respond to this drug for weeks to months. And so it is a good option if there are no other options available. And this is a diagram of CAR T-cell therapy. So some of you might have heard of CAR T-cell therapy in other settings, in other types of lymphomas or myeloma. But basically, the way CAR T-cell works is either the patient's or the donor's T-cells, and the T-cells are the natural immune cells that defend against infections and cancers. These T cells are harvested and genetically modified, so they express a new receptor on their surface. So the receptors then seek out the tumor cells, in this case CNS lymphoma cells, and attach the T cells to the tumor cells, and then the T cells is able to eliminate the tumor cell. So I've got a short diagram or short video here from the University of Philadelphia. So this is the CAR T cell in this case. The genetically modified T cell is the white cell, and you've got two blood cancer cells here in green. And you see that once the white cell attaches to the green cell, you can start to see the green cells start to shrink and start to change its shape and signaling basically the death of the blood cancer cell. So it's pretty quick. So we'll see how we go. It's a short and quick video, so hopefully you did see that, the white cell attaching to the green cell, making the green cell start to change shape and size and start to shrink and die from the T cell. So it's already been shown to be very effective in other types of lymphomas, and CNS lymphoma is something that it's shown good promising effect at the moment, but it's still under investigation in a clinical trial. So hopefully we will see some really good results with this therapy in the future as well. So obviously, as hematologists, we're not just treating the cancer cells, we're not just treating the tumor, we're treating the patient as a whole. So apart from the chemotherapy, the radiotherapy, the novel therapies, we need to consider obviously other supportive management issues for a patient with CNS lymphoma. So a lot of these patients will present very deconditioned, and whether it's due to the disease or due to the chemotherapy treatment. So rehabilitation, is very important part. So the rehab is a very important supportive measure for patients with CNS lymphoma. It's something that really we need to planning from the very beginning of our treatment of these patients as hematologists, and quite often we would engage allied health workers such as the physio and OT, all these other professionals to participate in the care of our patients with this CNS lymphoma, especially for patients that have pretty bad neurological deficit to begin with. It is important to tailor make their the neurological rehab so that they can make a quick recovery from their disease or treatment. The other thing is also, as I mentioned, some people can present with neuropsychological symptoms, and it's important that we monitor the neuropsychological part of the patient's care so that we can use that as a way to monitor whether the patient's responding to the treatment or not. So if a patient's cognitive decline or impairment is due to the CNS lymphoma, the decline or the impairment should improve with treatment. And we like to see the patient get better and better from that point of view, and memory start to come back, and the physiological or mental deficits start to improve as the treatment goes on, as a way of demonstrating that the lymphoma is responding to treatment. So that's also very important. In terms of follow-up, in patients that have achieved a remission, the way we would assess their follow-up response would be with a clinical review, initially usually about 3 months and then 6 months, and usually up to about 5 years. And during those clinical reviews, patients usually come in, we would examine them. We obviously take a thorough history. Sometimes we would follow that up with scans, so MRI of the brain or the spinal cord, and all eye exam if they did have eye involvement to begin with. It is important to not just look at whether the lymphoma is still in remission, but also to look at the potential side effects or the toxicity or toxic effects that the treatment has impacted on the patient. So looking at if there's any neurological side effects or other side effects from treatment. And quite often these patients will require regular blood tests to make sure that the bone marrow function is still adequate. After 5 years of follow-up, if they're still in remission, we will consider these patients to be in long enough remission to be cured. And so usually at 5 years, we would think about discharging the patient back to the patient's GP's care. Now, obviously, someone with a cancer history or lymphoma history, it's not a 0% chance of a relapse after 5 years. It's just the chance is quite small enough for us to discharge the patient. But there's always, there should always be ongoing follow-up with the GP, even after that amount of time, to make sure the patient stays well and the lymphoma stays away. In terms of prognosis, I've mentioned this a few times. Unfortunately, it does have a worse prognosis compared to the other types of lymphoma. So the 5-year overall survival is around about 40%. And this international group called the International Extranodal Lymphoma Study Group, they have done research in this area and found some higher risk factors for patients that have worse prognosis compared to other patients with CNS lymphoma. So if you're older, aged more than 60, if your functional state, so what we call ECOG, which is how well do you function as a person, in terms of your energy level, how active you are, how energetic you are, performance score, that's also important. This biomarker in the blood called LDH, if it's elevated, that portends a worse prognosis. Elevated protein in the fluid, in the CSF fluid around the brain spinal cord, and also if the disease affects the deeper areas of the brain. So these are all kind of risk factors for higher risk disease. The more risk factors you have, unfortunately, the worse the prognosis. So that's something that the hematologists certainly will look at the beginning of the disease treatment journey. And relapses, if the disease was to come back, it's usually within the first 2 years. And unfortunately, as I said, the prognosis for patients with either treatment-resistant disease or relapse disease remain poor. And so if we decided not to treat a patient, if the patient decides not to have any further treatment in patients that have had relapse disease, of disease coming back after a short period of time, unfortunately, the life expectancy is quite short, within 6 months. So in conclusion, CNS lymphoma is a rare and aggressive lymphoma. Most patients respond to treatment, although, as I mentioned, relapses can occur, and it's fairly common in this context, especially in patients that did not receive intensive chemotherapy to begin with. Treatment depends on the patient disease factors. Chemotherapy and radiotherapy remain the cornerstone for treatment in this disease. Consolidation after the initial induction treatment with transplant, stem cell transplant, or radiotherapy are the two options. And some of the newer medications appear to be promising, but more research is really required to try to improve the treatment and the outcomes for the patients with this disease. So that is my final slide. And so thank you very much for your attention. And yeah, welcome any questions you may have. Thank you.
Thank you very much, Matthew. So we do have some time now for some questions. If anyone has any questions, please feel free to put some in the Q&A, which is just at the bottom of the Zoom there. We do have a question from one of the lymphoma nurses. So are there any inequalities in access to care for primary CNS lymphoma, and how can patients advocate for themselves?
Yeah, thank you for the question. So in terms of inequality, I think that we are in a very lucky country. I mean,
Mm-hmm.
Australia's health system in general is pretty good. And because of our PBS and Medicare systems, for patients that have this condition where as hematology is able to access most of the drugs we need, certainly the chemotherapy and the radiotherapy as frontline therapy and the transplant as frontline therapy, there shouldn't be any significant inequality. Especially in the bigger centers. So the only thing I will mention is the fact that we know that rural or regional patients tend to have worse prognosis in terms of cancer treatment and cancer outcomes. So although we do have a good health system, rural patients tend to present later and usually tend to not respond as well to treatment. So it's important for the rural patients to seek additional help or second opinion if there's any concerns from their point of view. Most of the hematologists and oncologists should be pretty well equipped in delivering treatment in the regional area. However, if there are any concerns, it's always good to contact maybe an academic center or tertiary center in the city in terms of getting a second opinion or further advice. But as I said, going back to the access of drugs, chemotherapy and radiotherapy should not be an issue in terms of access, even if you're from the regional area.
Fantastic, thank you. We do have a question now from our audience. So question is there any scope for Bruton tyrosine drugs to go on the PBS, or will it remain for compassionate supply only?
Yeah, that's a very good question. Unfortunately, at the moment, ibrutinib is only available in terms of CNS lymphoma on compassionate supply. So the Bruton tyrosine kinase drugs can be accessed for other types of lymphoma, but not this one. It hasn't been PBS listed. So in the short term, I think it will remain a compassionate supply drug. As far as I'm aware, I don't think the drug company that makes ibrutinib at this stage has any inclination to try for PBS access, unfortunately. So, yeah.
Okay, thanks for that one. I just had one other question. With CNS lymphoma being quite localized within the CNS, is there any research into like other types of intrathecal treatments that we could potentially give in the future? Or because at the
Yeah.
moment we're always limited on what types of chemotherapies that we can give intrathecally.
Yeah, so thank you for that. So I didn't
Mm.
really talk about intrathecal chemotherapy. So
Mm.
intrathecal chemotherapy in the form of methotrexate again, or cytarabine or dexamethasone are often used in many different types of blood cancers. Now, in CNS lymphoma, because of the high-dose methotrexate, which penetrates into the brain space
Mm,
effectively, and all the other CNS penetrating drugs, intrathecal treatment, it's not usually necessary as long as you follow the protocolized treatments, which involves a lot of the CNS penetrating drugs already. So if you think about the intrathecal methotrexate, which is a percentage, only a very small percentage of what we give to patients intravenously,
mm,
the intrathecal often is not required if you use the common regimens that we use.
mm,
That includes matrix and RMPV. That's already got very high dose methotrexate in it.
mm. Okay, well, that's good to know. Um, Excellent. So we just have more a comment. This has been an amazing presentation.
Oh, thank you very much. I hope everything was clear and easily understood. So
Excellent. We've got another question. What are the future treatments for T-cell primary CNS lymphoma?
yeah. So going back to T-cell lymphoma versus B-cell lymphoma, unfortunately, T-cell lymphomas are the poor cousins of the B-cell lymphomas. So T-cell lymphomas tend to be more aggressive and less effective in terms of treatment and less targeted options available for T-cell lymphomas in general. So T-cell CNS lymphoma in particular is even more rare, and the response rates worse than B-cell lymphoma. So unfortunately, at the moment, the way you treat T-cell CNS lymphoma is pretty similar to how you would treat B-cell CNS lymphoma. But all the drugs that I've talked about, the CAR T and the brutinib, they're more for
Mm,
B-cell lymphomas. And therefore,
mhm,
again, in terms of novel therapy, there aren't that many novel therapies that have been shown to be effective in T-cell CNS lymphoma because it's even rarer and our experience is even less in this context and less targetable options for novel therapies.
mm. Okay. All right. I think that's it. So, uh, any last questions? No one's typing? Nope. All good. All right. Well, we might wrap it up then. So, thank you everyone for attending the webinar this afternoon. We've really appreciated your time and hope that you have all been able to increase your knowledge on primary CNS lymphoma. And thank you once again to Associate Professor Matthew Ku for being with us today and sharing your expertise. We understand that this may be a lot of information to take in, and if you have any questions or concerns regarding the content that's being covered today, or you're needing a bit more information, just please reach out to us at Lymphoma Australia, either via email at nurse@lymphoma.org.au or via our nurse support line, which is 1800 953 081. So we'd love to see you all again in our upcoming online or in-person support groups or at future webinars or events. So keep an eye out for our emails and always check our events calendar on our website for future dates as well. So thank you, everybody.
Thank you, Nicole. Thanks, Lymphoma Australia. Thanks
No
everyone for
worries.
joining the call. Bye
Thank
bye.
you. Bye bye.